I really wish this
Thank
platform was
you.
available when I was a PA student or like before I got into PA. I mean, it's amazing how much insight you get.
Hi, everyone. Hi, welcome. Welcome to eShadowing. Hey, guys. Hi, I'm Rodalyn, as you all may know. And today we have a very special guest. We have Prabhdeep. Prabhdeep is a general surgery PA. So today's going to be all about surgery, okay? And hi, Prabhdeep. Thank you so much for coming on.
Thank you, Ryan. Thank you for having me. I'm very excited. Hey, everyone. I hope everyone's staying safe in the midst of this pandemic. Let's get started. I'm very excited.
Yes, yes. So Pradeep has been a PA for 5 years, and right now he's in general surgery. Along with being a general surgery PA, Pradeep has a great platform called Ace Pants. He has a YouTube page and an Instagram page. So we're going to discuss that a little bit. He prepares all of you not only to ace your pants, but retake your board exams once you become a PA. And the PANCE is not just the test that you take, to pass your boards, but you're going to be studying for the PANCE the minute you start PA school. So I urge all of you to follow his page and start learning everything, and getting some information on what you're going to be essentially studying for while in PA school. So I'll attach his Instagram, but we're first going to start off by asking Pradeep to first let us know about how he landed upon the PA profession and why he decided to become a PA. So tell us a little bit about your journey.
Basically, I heard about the PA program first at your college. There was a seminar there going on, and that's how I found out about PA. I really didn't want to I didn't want to become a doctor because it was just way too many years. And then when I found out about PA from your college, I was like, this is it. This is my calling. So I found out about the program at St. John's. I knew it was a 4-year program. 2 years was in bachelor's, and then 2 years was a PA program. So believe it or not, that's the only program I applied to, and I got in. And yeah, that's how it all started.
Wow. So you applied one time and got in after that.
Yeah, exactly. I got into the bachelor program, and then you just got to maintain certain amount of GPA and take certain courses that they tell you to. And if you do well in them, then just you have a guaranteed interview with the same
Okay.
program. And then after that, if you ace the interview, if and you have good grades, then there's really no problem for you to get into the program.
Nice. Okay, so you got in you applied what year in college? Did you apply, or did you find out about the PA profession?
I found out during my junior year. So I guess it's a long time ago. I don't remember what
Okay.
year it was, but yeah, during my junior year, I found out about it, and yeah, I applied during my senior year, and I got in, and yeah, that was it.
Yeah, and that's kind of been the story. Like I always say, PA is still a new career compared to other healthcare careers, and that's been the story for a lot of people, kind of finding out about the PA profession later on in their college years. So they had to really work to get those healthcare hours and get everything together for the application. So, what did you do for healthcare experience?
So I actually worked with a primary care doctor. I rotated there, did volunteer work, and I also did some research hours at New York Presbyterian Queens. So basically, they do retrospect studies. They already have the topic decided. Basically, what my job was to just pick the data. For example, one of the studies was what's the most common symptom that a pregnant lady comes in with who doesn't know that she's pregnant yet. So we were looking at things like abdominal pain, back pain, nausea, vomiting, things like that. And so we basically picked the symptoms and the female gender, and then out of that we saw how many of them were actually pregnant, non-pregnant. I never got to see the study through because I started PA school at that time, but yeah, that's the clinical experience that I had going into
So,
PA school.
so it wasn't actually work experience; it was like volunteer.
It was a volunteer. I didn't
Oh, that's
get paid for this. Yeah. We
oh
also went
wow.
into ED
Okay.
actually. One of the studies was it was actually more to evaluate how fast the patients were being seen by the clinician from the time they come in. So we were directly going to the patients and families and talking to them and noting down all the data and whatnot. It was quite intensive. I'm telling you, it was long hours.
So, and that counted for your patient care hours, because schools tend to be strict about that. the hours that you need?
Yeah, my patient care hours actually came all from primary care, doing volunteer work there at a primary care
Okay.
office.
Wow. So it was
This
all
was just,
volunteer work.
right, exactly. But this was just, kind of extra to make my application look better.
Oh wow, wow. Okay, so how did you end up doing volunteer work? Like so where you were able to like get direct hands-on experience? Because students ask me all the time about like that getting accumulating those hours, and it's really hard.
Yeah, no, so I actually knew this doctor beforehand. He was like kind of our family friends. So that's how I got into the clinic and got the hours. There were a couple other doctors that they were there. And yeah, that's how I found out about it, and that's how I got the opportunity. But the thing is, now the hospital is getting very strict with shadowing, because of the HIPAA laws and regulations. But back when I was a PA, they were still allowed in the hospital to shadow, but I don't know if that's allowed anymore. So it's much harder to get shadowing hours now than it was before when I was trying to apply for PA school.
Let me turn my okay. Okay, great. So, can you tell us a little bit about your well, once you started PA school and then graduated, what like did you want to do? What was the first specialty that you ended up doing?
Honestly, I'm not even gonna lie. Going into PA school, I had no idea what specialty I wanted to go into. But once you start studying and stuff, my mind changed all the time. First, I wanted to do internal medicine. Then I wanted to do cardiology, and then I wanted to do neurosurgery, cardiothoracic, then ICU. Like I changed my mind all the time. But then after I graduated, I reassessed everything. Then surgery and ED were the two things that I wanted to do. After I had finished my rotations and I got to see exactly what the roles of PAs were in each specialty, that's when I was like, it's gonna be either ED or surgery, one or the other.
Okay, and what did
Throughout the PA school, I was changing my mind constantly depending on what I
you?
was studying at the time.
Yeah, everything seemed cool, I bet.
Exactly.
And what did you end up doing first?
So right out of school, I got my first job was as a surgical PA at New York Presbyterian. And we were responsible for covering 10 surgical services. Basically, we covered all surgical services except cardiac surgery, OBGYN, and orthopedics. Those are the only three things I don't have experience in. Except that, we did general surgery, colorectal, plastics, ENT, urology, neurosurgery, thoracic. I'm not sure if I said urology, ENT, OMFS. So basically, it was everything except those three. And I also got a per diem position in the emergency room. I had actually rotated that hospital during my clinicals. So they were kind enough to give me a per diem position. So I started the surgery at the same time.
Wow, nice. That you had two jobs.
I needed the two jobs.
I bet.
Yeah.
If you don't mind me asking, just so the people can know, how much were your student loans out of school?
Oh, actually, my dad tricked me into that one. He paid my student loan, and then I had to pay the mortgage.
Nice, nice.
But that was a bad deal on my part because the mortgage is a lot more than my loan. But I think my
Wow.
loans were about, I would say, I think they were 70,000. I got some
Okay.
financial aid and some scholarship. So
Okay,
in total
good.
for the whole program, I think it was about 70,000.
So now that you're in surgery, can you tell us about the day in the life of a surgical PA? From when you clock in to when you clock out, your hours, schedule.
Yeah, for sure. So basically, I do nights only. So my night usually starts around 6:30. So I do general surgery and vascular. I cover both of them. So I would get signed out from both of the teams. For general surgery, I get the sign out from the residents, and for vascular, I get it from the PAs. So that usually takes about anywhere from 20 to 40 minutes, depending how their day was. Once I get the sign out, I see the sickest patients that I have on my list. Usually, as I'm getting the sign out, I will have an idea who's the sickest. So I'll make quick rounds. And for the sickest patients, I would go talk to the primary team. If it's admitted to the ICU or the medicine, I will either go talk to the attending or the medicine team. Like, let them know what we're looking for and when to call me overnight, right? Like, if something happens, I want them to know when to call me, right? And once you have a conversation with them, they're less hesitant to call you, right? because I want to make them comfortable. Be like, hey, if this patient starts bleeding, or if you notice the HN is going down, call me right away. I want to be the first one to be known. Same thing if it's my if we have primary patients that are admitted to surgery, then I would go speak with the nurses, tell them what to look for. Hey, do frequent vital signs. Even though on the floors we don't do frequent vital signs, there's some times when I tell the nurse, hey, do it every 2-3 hours, and they're nice enough to do that. So once I've stabilized the floor, I know everyone is fine. I've gotten a baseline exam on them. Then I just wait for any complications to happen on the post-op patients, or if there's new consult or admission that comes through the ED or anywhere in the hospital, really. And if there are any cases that were done during daytime, and usually we do post-op checks on them. The post-op check usually happen about between the window of 4 to 6 hours after the surgery is done. So we just go check on them, see how the patient is doing, make sure they're not developing any post-op complications. So that's how it really starts. Mainly, the majority of the work is from the consults and admissions. Usually, we will see anywhere from 2 to 4, sometimes even 10 consults or admissions, which is a lot for one night. And I'm the only one there, so there's no one else. There's no in-house attending, no the resident or the PA. So I'm taking care of both of those services. So, sometimes it can get hectic. There are times when there's nothing going on. And then there's time when, I feel like if there were even 2 PAs, it still wouldn't be enough to, handle all the work. So it can vary drastically. But overnight, you only take care of acute stuff, These are all either, whatever's happening, it's all on me. I can call the attending whenever I want. But usually my goal is not to disturb them unless I have absolutely no idea what's going on with the patient, or if the patient needs to go to the operating room. That's the only time I bother them. Otherwise, I would just let them know in the morning. I'll just shoot them a text. Hey, I just admitted this patient. This is the plan. And they would just look at it, either respond right away, or they usually get back to me in the morning. But usually I'm the one who has to come up with the plan. I need to know what I'm doing with the patient. If I ever call a surgeon, I better know what I'm doing. Otherwise, because they're not there. I'm their eyes. I'm doing everything. So they got to be able to trust me. So usually overnight, you have a lot of autonomy as a PA.
Wow.
From daytime, because daytime is more, elective surgeries. You do see consults, but the attendings are usually in-house. Even if they're not in-house, you can always call them. It's daytime. They're up anyways. So if you have any question, you can always call them during daytime. Nighttime is different, obviously, because, surgeon's life is tough. They work 5 days a week. Out of the 5 days, 3 of them are usually OR. And then they're also taking call at night and weekends. So my job is to make their life easy and not disturb them at night.
Wow. Okay, so I just want to backtrack a little bit. One, how long did it take you to build that autonomy, especially with surgery? And then, what kind of training did you need when you started off as a new grad or just an inexperienced PA going into surgery?
So I was very lucky to start at NYP. My training was extensive. My training was for 6 months. Because we cover a lot of surgical services, and that was for night position as well, by the way. But initially 6 months, I was on daytime. Sometimes I would do nights and whatnot, but mostly it was days. So I would go to the OR frequently. If there were any consult for any service, I had to go see. They also sent us to Cornell Medical Center, where we would practice, surgical skills, especially like laparoscopic and whatnot. So a lot of my experience came from there, and ED as well. I used to work in Lincoln, and they have a huge population. It's one of the busiest EDs in America. So that's how I built my experience. And based on that, after the 6-month period, I got comfortable, right? Once the attending hears you presenting the case and you giving the plan out, they get more comfortable with you, right? They're going to ask, at the beginning, they ask us questions and whatnot, just to make sure we know what we're doing. If at the end of the presentation, the attending has no question for you and all they say, okay, that's fine, that means that they started to trust you, right? And that's when you get the full autonomy at the end of the day. You got to get to the point. Give them a plan which they have no objection to. But I would say for me to get fully comfortable, it took me a year and a half to develop that type of confidence. Even those times when I'm like, I don't know what to do for this patient. And, that's the thing as PAs, we got to know when we need to ask for help, right?
Right, exactly.
If you need help, you call them. You might get yelled at or whatever. Usually they don't. Very rarely that will ever happen. But if it does, who cares? They're going to forget it the next morning. The biggest thing is the patient is safe, and you don't get a call in the morning saying you messed up overnight. That's the biggest thing. So I think the main to build autonomy, you got to know when to call the attending, when to ask for help. That's the biggest thing. Know your limitations, and obviously that takes years to build. For me, it was I would say a year and a half, and the only reason why I was able to do it in a year and a half was because I was working a lot. I was working ED and surgery. I was working at least 4 to 5 days a week, so I built up a lot of experience over time. If it was just doing surgery, it might have taken me longer, maybe 2 to 2.5 years. But yeah,
Wow.
because at NYP we had one or two other PAs, so it was more helpful. You have someone more experienced than you to guide you through everything. But right now I don't have anyone. I'm by myself. So the only reason why I'm able to do this job is because of all the experience that I have from my ED position at NYP.
Wow. That was a lot of insightful information. Thank you for that. Thank you. So let's see what they have in the chat. Somebody asked you actually what was the best advice you can give to PAs or pre-PAs. Is that what you think is the best advice to, knowing, when you don't know something and knowing when to consult with the attending and whatever, you don't feel comfortable with?
That's the biggest thing.
Okay.
For me, I'm on at night and we don't have direct contact. Sometimes I don't even see the surgeons for like months and months, right? I only see them if they come if they come to the hospital. So if I make even one mistake, I could be right 99% of the time. I make one mistake, I'm wrong the one time, they're not gonna be able to trust me, right? And every time I call them, or they're gonna want to know every single detail about that patient the next time I call them, right? You lose that trust relationship with them, and the only way you can build that is if you know when you don't know, and you ask them for help. That's the biggest thing. Yeah, that would be the advice that I would give you, because as PAs we can work independently, right? Whether that's in urgent care, ED, primary care, surgery, internal medicine, we can work independently. So it's very important to know what your limitations are, because obviously, let's look at a doctor, right? It takes them 4 years in med school, and then 4 years or 5 years of residency, and now almost everyone has to do fellowship. So all in all, they have 10 years of just extensive studying and working, whereas we do that for 2 years. 2 years, and then we start working, and majority of us are working like 3 days a week, whereas as a resident you're working 5 days a week. So they have a lot more experience and a lot more knowledge that we don't have. So not only, a lot of PAs get comfortable after you graduate, right? They
Right.
don't understand research that, they don't build themselves up. And that can be problematic. And I've seen that a lot of the time, especially in the ED and internal medicine. I've seen a lot. So the biggest thing is keep up the good work, keep up with the studying even afterwards. And once you do that, you will know your limitations. You will know when you don't know enough. Okay. There are a lot of times you can look things up, and you're gonna have to do that. There's no way you're gonna know everything. There was even till this day, there are things that I don't know, and I still learn about them as I'm seeing consults. So, I would say that is the biggest pearl, knowing when to ask for help as a PA.
Wow. Yeah, I completely agree. And I tell them that all the time to, know what you don't know. It's okay to not know and to ask for help, especially as a new grad. Even, when you have a couple years of experience, you just don't ever want to miss that one case, that one diagnosis, have something terrible, an adverse reaction or adverse event happen to the patient because of, just a simple mistake. So I definitely agree with you.
This was a common thing that was said when I was a student, that a PA's job end when he clocks out, right? And that is so wrong. It's not true at all, right? I've gotten calls, text messages after I've left. I have followed up on patients after I have left. Your job does not end when you clock out. Unfortunately, it doesn't. Unless, you have no feelings for the patient and you don't care. I mean, that is different. But there's so many times when you're like, is that patient fine? Your job does not just end there. You know what I mean? If you make any mistake, they're going to call you. They're going to contact you the next day, asking you what you did wrong and why you did what you did. So, Yeah, you're absolutely right. You don't want to make that mistake because that mistake will affect you mentally down the line.
Exactly.
Every time, if you have a horrible end YouTube experience, that's gonna haunt you. You know what I mean? There's so many of these things when you start practicing. Some of them scar you. Honestly, I'm not even gonna lie. You just gotta have a tough head to push through it and figure out what you did wrong and fix it the next time.
Yes, yes, I hear that. So, do you actually have surgery days where you're strictly in the OR?
No, so I don't. I have cut down my OR time a lot ever since I've been at my new job. It's only urgent stuff. Anything that's urgent that needs to go right away. For that, I was scrubbing. Otherwise, I don't scrub in for elective cases. I used to do that at NYP. We were covering so many services. You always had some sort of case going on, even at nighttime. Some of the elective cases will always go past 7 o'clock. So we have to go and scrub in, but not a month. I've cut down my OR time a lot compared to what I used to do at NYP.
Okay, cool. So I have about 3 more questions, and then we're going to go into case studies. And then I know a lot of people have been asking questions. We're going to try to make some time towards the end to answer the rest of your questions. So hold on to them. So somebody asked, is it just general surgery? Do you do knee and hip surgery, or is that strictly ortho? I believe that's ortho, just strictly ortho, but I'll let you answer that.
That's correct. Yeah, no, any joint stuff is all ortho. General surgery is mostly abdomen, even though it says general, but it's mostly abdomen, breast, colorectal. All those three kind of fall in general surgery. Now, for vascular, we can we do amputations and stuff. But again, if it's anything involving the joints, like joint replacement or bones and broken bones and whatnot, that's obviously all ortho.
Right. In general surgery is one of the rotation that's a required rotation for I'm just about every PA program. So you all will do a general surgery rotation. I actually did a vascular surgery rotation as well. Well, just because the surgeon I rotated with, he was also a vascular surgeon. So I was also there for I was setting up like dialysis ports. What is it? Also, I'm having a brain fart. Yeah, fistulas. Yeah. Also varicose veins. We did. It was a lot of. I probably did half general and half vascular. So for general surgery, can you tell me the common cases? Can you guys actually before he goes? Do you guys know, or can you guys tell us some of the common cases? You'll see them all the time on TV, probably on Grey's Anatomy, Grey's Anatomy, House. Can you guys tell us some of the common general surgery cases that you'll see, what you'll likely do in the OR?
Surgeries on them.
Yeah, the most common ones. Yeah, they're already saying them.
Yeah.
Yep, appendectomies and cholecystectomies.
Yeah.
Yes. All right. Yeah.
Oh, wow,
so can you tell us?
That's impressive.
Yeah, hernia repairs. Okay, so can you tell us about all those cases?
Yeah, so I would say the most common things we see in patient is appendicitis and cholecystitis. So gallbladder and appendix issues. Most common surgeries we do as general surgery. Now, outpatient is a little different. So outpatient, you're going to see more like hernia repairs, biopsies, cyst removals, the thing is, general surgery can also specialize, right? Like there's some people who just do minimally invasive, some do colorectal. So those things can vary. Like, for example, if you're doing colorectal, you're going to see a lot of colorectal stuff, diverticulitis, sigmoid volvulus, things like that, right? Or hemorrhoids, perianal abscesses. So it can vary. But for general surgery itself, I would say appendicitis, cholecystitis, small bowel obstructions are the most common things you see. And bowel obstructions are vast. You can have small bowel, large bowel obstructions, different types of obstructions. It's enormous. But I would say those three things are the most common. And at some hospitals, like at my hospital, we also take care of lower GI bleeds. Whereas some other hospitals, that goes to medicine, and surgery just might they might be consulted and whatnot, but at our hospital, we admit GI bleeds as well. So that's also quite common. But that can vary from hospital to hospital. There are a lot of logistics, depending on admissions and stuff, a lot of bureaucrat stuff. But for us, we also do lower GI bleed. We admit them to our service.
Yep. I also saw that on my rotation,
Right.
GI bleeds. Okay, so let's see. And then there was another good question that somebody had I wanted to ask before we start the case study. What was the most difficult or interesting surgery that you've ever done?
Ooh, that's a tough question. Oh man. Most interesting or difficult? Well, can you repeat the question again?
Most interesting or difficult case.
Okay, so interesting, I would say craniectomy is probably the most interesting. Seeing the brain swell up, that was.
Oh, really?
Yeah.
Did you guys assist the neurologist or?
Yeah. We used to assist in all. So it was a So that's another key difference, right? It was a PA-run hospital. My first job, and we saw the consults, we did admissions, we managed patients on the floor, and we went to the OR. So for like any case, like if it was a neurosurgery case, like patient had a head bleed and they needs to be decompressed, we took them to the OR. We first assisted the surgeon. Also spine cases, we would first assist them. Spine cases are long; those cases are monstrous. But yeah, I would say actually, there are a lot of interesting cases, but I would say a craniectomy was, back in the day when I just started off, it was quite interesting. And most difficult, I would say there was this patient who had this needle go through the abdominal wall, and we couldn't find it. We opened up the belly, we went into the peritoneum, we did a laparoscopy, didn't find it. Then we had to convert to open. We still couldn't find it. So then we did direct fluoroscopy, and we saw it's in the bowel wall itself. And we made 3 incisions, which was quite embarrassing at the time. We still couldn't find the foreign body. So we actually had to close up and leave it in there, yeah.
Wow, you said a needle?
Yeah, it was like
it was like a psych patient, or?
No, it wasn't. The patient just like fell on it, and it penetrated through the abdominal wall. Yeah.
Wow.
So we thought it was between the peritoneum and the abdominal wall. So we went in with the scope and we looked for it. We couldn't find it. And then, we started doing direct fluoroscopy, and we saw it was in the abdominal wall. And, we made incision. We tried opening. We just couldn't. We couldn't find it. Every time we would make an incision, it would move further down or up, and we just had to leave it in.
Wow.
And
so
you can leave it in, actually. Foreign bodies, you can leave it in. The body will just either just form a scar tissue around it and nothing will happen, or it will push it out. An abscess will form around it, and eventually will start pushing it out, and then you can take it out. So it is safe to leave it in there as long as it's not inside the peritoneum.
Wow. And you said you went through the peritoneum. Well, you guys looked through the peritoneum as well to look for it.
Yeah, we did. But the thing is, when we did direct fluoroscopy, we could tell that it was in the abdominal wall. It wasn't further down, because every time we would make an incision, it would start moving. So yeah.
Wow. That's insane.
We were in there for a long time, and we couldn't. Yeah. And my surgeon at a point gave up. He was like, "What do you want to do? Do you have any suggestions?" I'm like, "No."
Wow, that's insane.
I would say that was. I think that's the only. Yeah, that was a difficult case. Yeah, for sure. I mean, there are many more, but that's all. There are a few more that I can talk about, but I would say that was one of them, at least.
Okay, wow. Okay, and then we're going to move on to case studies, but right before that, I just want you to let the audience know a little bit about like what a PA would do during surgery, as far as first assisting and then like closure, and just the PA's role as the surgeon does what he or she needs to do.
That's a good question. The thing is, it can vary drastically, right? Obviously, if you're outpatient surgical PA, you're never going to see the OR. You will only manage pre-op and post-op patients. Or what you can do is, if you work with a single surgeon, what you can do is, like, you work 4 days or 5 days a week. Out of the 4 or 5, 2 days will be in the operating room, where you first assist the surgeon, and the rest of them will be in the clinic. If you're an inpatient like I am, then you would first assist the surgeon. Okay. Now, depending on the type of surgeries you do and who you do them with, I'm sorry, they might let you do the surgery itself. Depends on the complexity. Okay. If it's a simple surgery, they might, they're going to train you over time and they'll let you do it. I actually know a few PAs who've been doing it for years now, and they have a lot more autonomy in the OR versus some other PAs who just first assist. So again, it depends on the type of surgery and how much experience you have and how confident the surgeon is with you. But if you're just first assisting, then honestly, what you're going to be retracting and making sure the visual field is available for the surgeon. So your job as a PA is to predict what the surgeon is going to do next. Okay. For example, the gallbladder, right? If he's dissecting the gallbladder, make sure, like if he's done the right side, the next side is going to be the bottom or the top. So have that ready for him instead of him asking you, right? Once you develop that flow, the surgery is going to go much more quickly. A surgeon can be the most experienced, the best surgeon, but if you don't assist them properly, you can make them look like a fool. Okay, it's all about you can do little things to make their life easier. Okay, and obviously, if you develop enough experience and the knowledge, some surgeons would even ask for your opinion as to what to do, what not to do. Right, but again, that comes with years of experience, and obviously, you have to continue to study because again, like I said before, a surgeon, especially the surgical residency, is about 5 years, and then 2 years of fellowship. So they've been doing this for 7 years. If you think you're going to graduate PA school after 2 years, and then a year in, you're going to be giving suggestions to surgeons, I don't think so. But it takes time. But that's what is so rewarding as well. If you get to that point, like imagine how good you feel, right? You're actually giving a suggestion towards the surgery, towards the decision. You feel like you're on the team, right? So again, it can vary drastically depending on what type of surgery you're doing. For example, OMFS, oral maxillofacial surgery, like if you have a maxillary fracture or, you can do a lot more in those cases. We would basically lock their jaw. We would put a brace on the top and the bottom, and then we will wire their jaw shut. Because for 6 weeks, they can't eat or drink anything, and you don't want their jaws to move. So once you have shut their jaw, then you make an incision right under the lip, right under the upper lip, and you go in, dissect, see where the fracture is. Once you find the fracture, you put plates on it, and wherever the plate has the holes, you drill it in, and you put nails in it. Now, that type of surgery, a PA can do once you have enough experience. There were also surgeries that, my attending used to let us do. He would do one half, I would do the other half. So again, it can vary depending on what type of surgery you do.
Okay. And can you tell us, like, what's another simple surgery that a PA can do? Is it like a cyst removal? Because when I saw those, I'm like, okay, no, not a cyst removal. Because you have to know really the anatomy.
Right. But usually I haven't seen it being done. I'm sure if, someone has developed enough experience, they probably can.
Okay.
But no, that's something that probably the surgeon would end up doing. Let me see what else. Orthoscopes. I haven't personally done them, but those knee scopes and shoulder scopes, if the PA has been trained well, they can do them by themselves while the surgeon is there scrubbing and just guiding them as to what to do.
Okay.
Yeah.
Okay. Great. Thank you so much. There's still so many questions. I'm sorry, guys, if we never get to your question, but we're going to go through the case study. We're going to try to do at least one case study. And then if we have time, like I said, I'll answer your questions. But I did type out Prabhdeep's Instagram, ace_pants. Just follow him on Instagram, and I'm sure he'll be happy to answer questions that you guys have.
So live after this, if they want. If there are a lot of questions,
awesome.
I'll go live and we'll go through all of them.
Oh, thank you so much. Thank you so much. I'm sure they're very grateful for that. Okay, so does anybody want to join in on the case study? If you want to join in on the case study, then raise your hand. And like I said, we'll try to answer questions once he completes the case study. But if you want to join in on the case study, it's really cool. Just raise your hand. Somebody said yes. Okay, looks like Elise. So Elise was the first person. Okay. So Elise is going to come on. Thank you, Elise. If we have time for the second one, then looks like after Elise, it was Marianti. All right, Elise. Awesome. Hi.
Hi.
I can hear you, but I can't see you. Is it
Okay.
just my camera?
Did I do this the right way?
Okay, good now.
Hi.
Hi, thank you so much for coming on and volunteering. So you're going to be on as Prabhdeep goes through the case study with you, okay? And you're probably going to answer some questions as well. You ready?
I'm ready.
All right, let's
Okay.
do this.
Should wear my shirt.
All right, so we're gonna try to do two studies. The first one is gonna be a consult from the ED, and I'm gonna try to do my best to make it seem like how I would be called. Okay, so usually we'll get a page, and this page that I got was for a 75-year-old male with sigmoid volvulus on abdominal X-ray. Okay, so once I got the page, I called the ED attending. He told me that this is a 75-year-old guy from nursing home with a history of heart failure, hypertension, hyperlipidemia, diabetes, chronic constipation, chronic kidney disease, and he was demented at baseline. So the reason why he was sent to the ED was because he had abdominal distension and he was in respiratory distress. They were not able to get any history from the patient because he's demented at baseline. And unfortunately, there was no documentations from the nursing home either. Now, this rarely happens. Usually, they're pretty good with sending the things with the patient. But in this case, we had very limited information. And all the info that we got about the past medical history was from previous charts and whatnot. So in terms of vital signs, the patient was tachycardic, and oxygen saturation was at 95 on non-rebreather, and the blood pressure was normal. And on exam, he was very distended. And they got a bedside abdominal X-ray, which showed findings consistent with sigmoid volvulus. Now, ICU had already seen the patient for the respiratory distress, and they thought the respiratory symptoms were all because of the abdominal distension. Now, it makes sense, right? Because the abdomen was so distended that it was pushing on the diaphragm, right? And that's where the lungs weren't even fully expand. And he can't, the patient can't breathe in properly, so the oxygen saturation dropped. So they recommended that an NG tube be placed. Now, NG tube is a nasal gastric tube that goes into the nose. Sorry, let me see this. That goes into the nose and into the esophagus and then into the stomach. So the purpose of this tube is, right, to decompress the bowel. So since there's an obstruction, all the feces, the fluid, the air is going to back up into the stomach. So if you put a tube in and you suction all that out, the abdominal distension is going to go down, okay? So the ED attending, the EDPA, both attempted an NG2 placement, but they failed because these demented patients are very hard to do really any procedure on because they're very combative, uncooperative, and especially with NG tube, these patients need to swallow as you're putting the tube in because it's very important for the epiglottis to close down so your tube doesn't go into the trachea. Okay, if it goes into the trachea, you can cause them to have aspiration pneumonia, which is actually a pretty big complication of NG tube. So since these patients are really not following directions, and they don't, do the act of swallowing as you're putting the tube down, it can go into the trachea. And, it's very difficult to place the tube on these patients. It actually took me a long time to get used to it. But yeah, so they weren't able to place the tube in, and that's why they called me. So literally all this happened within 20 to 30 minutes of patient arriving. So the labs were pending, and the CAT scan wasn't done yet. Now, I just want to go over what sigmoid volvulus real quick. So as you guys all know, sigmoid colon is the transition between the descending colon and the rectum, correct? So what happens in sigmoid volvulus is this part of the colon just rotates on itself. When it rotates about 180 degrees, it forms a volvulus. And as you can see, it forms a nice and tight knot right here, right? Nothing can go through proximally, and nothing gets out distally. So the issue with this is that this part of the colon that's obstructed starts to get dilated. And once it gets dilated, it's going to cut off circulation that's coming here. Hold on, let me see if I can draw this out. So there's small blood vessels coming to this part of the colon that's supplying blood, right? But once this gets distended and the pressure is higher than that of the capillaries, it's going to completely collapse them. And if the capillaries get collapsed, you're not getting any circulation to that part of the bowel, and it's going to become ischemic. Basically, the bowel is going to start dying. So now, since you guys know that, now you understand the urgency of this pathology. This needs to be fixed as soon as possible so this bowel doesn't die off, okay? Once this bowel dies, you're going to have to take the patient to the OR and resect this out. So now knowing that, tell me what you guys want to know about this patient. As we know here, this is the information we have. What else do you need to know about this patient? And I'm talking about, this is from you getting the call and walking down to the ED. What's going through your head that you need to know from the patient, possibly? And how can you find out this information? Elise, do you know? Any ideas?
Something that just I think of is the patient on any kind of blood thinners or anything that could be complications for potential surgery.
Perfect. That's beautiful. So the main purpose here that should be going through your head is that this patient might have to go to the operating room. And if the patient has to go to the operating room, you need to know if the patient's fit enough to survive the surgery, right? So here are the things that we know about him, right? He has heart failure. So you want to know, how bad is the heart failure, right? There's something called ejection fraction, which measures how much of the blood that the heart can pump out into the circulatory, right? Usually 60, 55 is something we can deal with. So you want to know how bad the ejection fraction is in this patient, right? Secondly, we know that this patient has dementia. So clearly, if this patient needs surgery, he cannot consent for the procedure himself. So you want to know who else makes the decision for this patient, right? And what if the patient is DNR, DNI, if the family doesn't want anything done for the patient, if that's what the patient's wishes were before he became demented and that's what he told his family, then there's nothing for you to do as a surgical team, right? The patient needs to be on palliative care, comfort care, nothing for you to do. Another thing here that we need to focus on is the CKD, right? You want to make sure you don't give this patient IV contrast, right? Depending on if he's on dialysis or not. If he's on dialysis, then you can give him contrast because you can just clean the contrast out via the dialysis. If he doesn't, then you want to avoid IV contrast in this patient, right? So the main thing is that the point that I'm trying to make is you want to know what things will hold him off from going to the operating room. Blood thinner that's a wonderful idea, because if the patient is on blood thinner, especially like warfarin, and his INR is like 3 or 4, that patient needs to be reversed before he can go to the operating room, before you even can think about it. Because if you don't find the information out, the patient will literally bleed out on the table. So those are things you need to keep in mind as you're walking out. You don't have to sit down to think about it. These are things that will come to you naturally when you have done this enough, right? So those are things you need to look for. So once I went down, I saw the patient. I saw his abdomen was very distended. And, I thought the first thing that I needed to do was decompress him by putting the NG tube. So I was able to get the NG tube in. It's kind of tricky with these patients. You put in the NG tube. So the way you can do successfully is like you put the NG tube in about 20 centimeters, right? So you get it about here. After that, you watch how they're struggling. If they're gagging, right, let them gag. And then there's going to be a point where they're going to stop. It's going to be a split second. That's the time when you start advancing the tube, okay? It's worked for me all the time, all right? It's a very effective technique, but it takes time for you to get that sensation of when the patient is not struggling, okay? The main thing is you want the epiglottis to block the trachea. So you're not putting the tube into the trachea, okay? Because that can result in severe complications. But the problem here with this patient was I got the tube in, but I didn't get any return. Now, looking at his distension, I was expecting at least 1 liter of fluid coming out, right? Or at least 500 mLs, if nothing more. But nothing came out of the tube. It did, but it was very minimal. So does anyone know why nothing came out? Elise, do you have any idea?
I'm trying to think. The only thing I can think of is if the fluid's coming out a different way.
Like, think about it. So No, so it's obstructed. Remember, there's nothing going down and nothing going down at all. It's completely obstructed. But look at where the obstruction is, though, right? It's very far down. It's in the sigmoid colon, right before the rectum. So the bowel has a lot of room to compensate. You understand what I'm trying to say?
Okay.
So instead, like let's say the obstruction was right here in the small bowel. All the fluid would gather in the stomach a lot sooner versus if it was in the colon. If it's in the colon, it has all the descending colon, it has all the transverse colon, then the ascending colon, and all the small bowel. So it has a lot of time for it to before it makes it to the stomach.
Okay.
So that's why there wasn't much coming out from the tube, and that was kind of worrisome because we weren't able to decompress him. So he finally got the CAT scan done, which was consistent with sigmoid volvulus. His labs came back. White count was 15. WBC basically tells us if the patient has an infection or if there's an acute event going on, right? Anything above 11 is pathological. He had a lactate of 4, which is not too bad. You know, it is elevated, but, you know, he's probably dehydrated and he's probably losing some fluids from the obstruction itself. Creatinine measures the kidney function, which was elevated, but, you know, that's expected with a CKD patient. So now the management of this patient, right? If there's no ischemia or perforation, remember we talked about it earlier? If the bowel gets so distended that cuts off the circulation, you're going to start developing ischemia. And on the scan, there's certain findings that will tell you if there's ischemia or not, right? In this patient, there was no ischemia. Or if this patient has perforation, meaning the dilation got so bad that the colon kind of just popped, right? Like let's think about a balloon. You keep on blowing it, and at a point, it's just gonna pop, right? So it's sort of similar with sigmoid volvulus as well. So if there is a perforation, just think about it. What are you gonna see on the scan? Elise, do you have any idea?
If there's a perforation, then you'll see that fluid releasing to the rest of the body or the surrounding areas.
Right, but there's one key thing that we look for. Just think about what's in the colon normally, right? There's stool in there, there's air.
Yeah.
Right? So air is going to be very prominent with perforation. Like you can do abdominal x-ray, and if you see air outside of the bowel wall, that's an indication for perforation. Because unless you're not going to really see the fluid leaking out all that much unless you're doing it with a PO contrast, which you really don't want to do in a perforation. So the main thing you will see is air outside the bowel wall, right? So the management for this would be, if there's no ischemia or perforation, you call the gastroenterology team, right? And they come in, they do a colonoscopy. They go in with the scope from the rectum, and they, you know, reach the point where where the twisted bowel is, the volvulus is, and they push air through there. And the air sometimes untwists the bowel, and it opens up. And then after that, so the acute event is solved. The distension is going to go down and patient feels better. But you still need to do surgery on that admission. It wouldn't be right away. It will be maybe in 2 or 3 days or whatever, right? Like, for example, a patient like this who's 75, who has so many medical problems, you want to make sure he's medically stable before you take him to the OR. So the first line of treatment will be endoscopic decompression, where you put the scope in and you push air and you open up the volvulus. And then you will have surgery down the line. However, if there is signs of ischemia on the CAT scan, or the patient's hypotensive, or you see perforation, which is free air on the scan or the abdominal x-ray, then the patient needs to go to the OR emergently. You don't wait to call GI and for them to come and do the scope, okay? Now, in this case, the patient had no ischemia, the patient had no perforation. So the likely treatment would have been calling the GI team and having them decompress. Unfortunately, that's not what happened in this patient. The GI team came down and saw the patient, but didn't think the patient was a candidate for endoscopic decompression. They thought the patient was too unstable, and they were under the impression that the patient was developing ischemia, even though there were no CAT scan findings and the lactate was normal. So the GI attending just didn't feel comfortable doing the scope. So at that time, you know, it became a very it was a very bad situation for the patient because you want to decompress the patient because if you decompress the patient, there's a lot of room for us to do a case laparoscopically. Okay, let me draw this out real quick. So this is the abdominal wall, right, for the patient. Usually we have about this much room, and this is the bowel, let's say. We have all this room to work with when we're doing laparoscopically. You guys know what laparoscopic is, right? Elise, do you know what laparoscopic surgery is?
I thought it's through the skin and with like a camera, but I'm not
Exactly,
sure.
exactly.
Okay.
We make small incisions, right? And we go
Mhm.
in with the camera. And once we make the incision, we put in the scope and we push air in, okay? Once we push the air in, the abdominal wall raises up from the bowel wall. So that way we have this much room to do resection, dissection, and just look through what's going on. It gives us a visualization room, right? But in this patient, that wouldn't be the case because he's already very distended. So even if you push air in, it's not going to make any difference because the bowel is going to be almost touching the abdominal wall. So if they don't decompress this patient, then we have no choice but to open up the belly. So opening up the belly would mean going from above the umbilicus down to the pubis. Okay. So the GI team didn't, they weren't amendable to doing the scope. So we had no choice but to take the patient to the operating room. And we did take him, and he was the classic case of sigmoid volvulus. So usually the epidemiology of these patients is they are 70 and older. It usually happens in males. They're usually nursing home patients or bedbound, and they have history of chronic constipation. Now, if you think about it, right, why does it happen in the sigmoid volvulus? So if you have chronic constipation and you have stool sitting here all the time, right? That stool burden is gonna make the sigmoid volvulus elongate. It's gonna become nice and long, right? And once it becomes long, it becomes redundant. So it's easier for it to rotate on itself. Whereas a healthy patient, when it's nice and tight like this, it's not gonna move a lot. It's not gonna have a lot of room to move around. But when the stool load on the sigmoid volvulus, on the sigmoid colon, it stretches it out, okay? Especially with the gravity pulling it down, right? And it becomes elongated, and there's a very high chance that it will rotate on itself. So that's what when we opened them up, that was exactly the case. The sigmoid was huge, and we had to proceed with the surgery. But there are three ways you can do this, right? Well, not really three ways you can. There's only one way to do it, but these are three scenarios possibly. So you can untwist the sigmoid colon, right, and then be done with the case, and you close the abdomen, and you're done. Or you can untwist the sigmoid colon and then tie it down so that it doesn't happen again, right? So it doesn't move on itself and rotate 180 again. Or you can untwist the colon and resect that part out. So Elise, which one would you, if you were the surgeon, if you were operating, what do you think is the best course of action here, and why?
I think probably for me, what I think is B2, to untwist and then to tie it down rather than do a full resection, because that seems like there could be more complications and the patient is already kind of at higher risk.
Right. So you have the right thought process. You're absolutely right. Colon resection is a big procedure, right? And there is a high rate of complications, especially in a patient like this who's old and it's not going to recover too well, right? But unfortunately, the answer is three. So you really can't tie it down, right? Because there's so much going on. There's so much small bowel. You really don't have any place to really tie it down. So you really got to take the sigmoid colon out. But really good thought process though, because doing a resection, it's a big surgery, and that's why we like GI to do endoscopic decompression, so the patient's out of danger, right? And then we can wait a few days for the patient to be stable, and then do the surgery. But in this case, the patient didn't have that opportunity, so we had to resect the colon out, because if you leave it in, there's a very high chance it's gonna happen again. Okay, but the patient did really well though. Surprisingly, he did well. Was discharged home. Discharged to nursing home, and overall there weren't any necessary major complications. This. I have a second case, but if you guys have any questions about this one, Rodlin, if there are any questions that are out there you guys want me to answer, I can before moving on. Or do we have time?
Yeah. Well, it's actually 8 o'clock, or just about to be 8 o'clock. Time went by really fast. I know, time went by really, really fast. So, unfortunately, we don't have time for the second case, but that only means that you're gonna have to come back.
I'd love to do that. I would love to do that. I feel like there's so much
Thank
more
you.
that I can talk about here. But
Yes, they
definitely,
loved it.
100%.
They said you're very detailed, and I think you're a great teacher.
Oh,
Yeah, thank you
Really
so much
appreciate
for
that.
explaining all of that to us.
No
Yes.
worries.
Thank
Elise,
you,
that was really
Elise.
good, by the way. That was amazing. You have a really
Thank
good
you.
insight already. I'm very surprised.
Thanks.
Thank you.
Amazing.
What
Amazing.
are you? What year are you in college, or have you graduated? Like, where are you on your journey?
Yeah, I've graduated. Now I'm really just like in the middle of the first application cycle. I'm working as a clinical assistant in the neurosurgery center.
Oh,
Awesome. Good luck. So you're applying. You've already applied, or you're applying for 2021?
So I've already applied. I was waitlisted with one program, and I'm still waiting to hear on a couple others. So.
Oh, I'm sure you'll get in. You will get in. You did great.
good luck
Thank
with
you.
that, but you should definitely go into surgery. I'm not gonna lie.
You got me excited for it.
I'm glad.
Thank you.
Thank you so much, Elise. Alrighty. So, unfortunately, it is 8 o'clock. Thank you so much, Prabdeep, for coming on. So sorry, guys. I know you guys still had a lot of questions. I don't even see a lot of the questions anymore because they disappeared through the chat feed. But let's see. I think somebody said, "How do you tie it down?" Specifically related to the procedure for the last case.
You can't. I just literally bait that up.
Oh, okay. Sorry.
No. I got that from a urology case. So when you have testicular torsion, you can do archaeopexy. So you can tie it to the scrotal sac. So it's basically the testicle like kind of rotates on itself and loses the circulation, right? Testicular torsion. So when you take them to the OR, you untwist the testicle and you tie it down to the scrotum. So that's where I got the idea from. But for sigmoid colon, you can't tie it down. You just got to take it out.
Okay.
I had a feeling.
Okay.
That, so I'm sorry. I was just...
Thank you so much.
You have a really good thought process behind it, though. So that's very impressive.
Alrighty. So, like I said, it's 8 o'clock. So you guys, like Pradeep said, he's gonna be on Instagram. He's gonna go on Instagram Live after the session. I will stay behind to answer general PA school questions. But if you have questions related to surgery or want to know more about Pradeep's journey, Ace Pants, anything he plans to do, follow him on Instagram and his YouTube page. His Instagram is ACE_pants, PANCE. His YouTube is Ace Pants, just spelled out regularly, ACEPANCE. So I'll put that again in the chat box. If you guys have questions, once again, I'll stay around for a little bit, but follow Pradeep. He's going to go on live. Thank you so much again, Pradeep. I really enjoyed it. And he's going to come back next time. We don't know when yet, but he's going to return for a second surgery part 2.
Just let me know when. I'll be back. I love this. This is truly amazing. I kid you not. Like, we were having this conversation before. Like, I really wish this platform was available when I was a PA student or like before I got into PA. I mean, it's amazing how much insight you get. I was on the last one that you guys did last Monday. I even saw the one that you did, I think a few days ago. It's amazing. You get so much insight.
Yeah.
It's really, really good. You guys are so lucky. You guys don't even understand. But
yeah,
I'm gonna go live I think at 8:10. I'll go live. I'll be back in 8 minutes or so. If you guys have any questions, we'll go through everything. And I might, if I figure out how to do this, screen sharing on IG, I'll go to the second case as well. If not, then next time.